Well, welcome everyone to the first Leading Voices in Public Health lecture for the new academic year. Please sit in such a way that you can see the screen. We thought the screen would be in the front, but it's over there. But I figure after 2.5 years of COVID, we're all able to adapt on the fly, right? So tonight we're going to be talking about Appalachian health, particularly the book, Culture Challenges and Capacity. But I wanted to say a few words about the lecture series before we start, because some of you are new to the area, to the region. We've been doing Leading Voices for the last 15 years, and the idea was to bring in people from outside the region who can talk to us about issues of real importance to the public's health. We've had 66 events, and after tonight, almost 100 different speakers. But what's important is that we have academics, we have researchers, we have authors, we have had entertainers, and really the whole idea of the series is let's learn from folks outside what we can do to improve health in our region. And if that's the wrong button to press. And if you want to go onto the website, you can actually see many of these lectures recorded. But tonight we're going to flip it around a little bit. Instead of asking the question, sort of, what can we learn from folks on the outside? Let's ask the question, what are our issues that we need to deal with here in Appalachia? And so that gets us to this book, Appalachian Health. Many of you saw the book. I should have a copy here to hold for you, but I don't. There it is. David has a copy. That may be the last one. If you want one, you better get out there and get it right now. The book began a couple of years ago when I got a phone call from Doug Scutchfield, who is, for many of you know, he was a real legend in public health and one of the rare guys. And when Scutch calls you up, you know, I mean, he said, do you want to co-edit a book on Appalachian health? I didn't have to say, look, I'll get back to you on Monday kind of thing. So we did the book. Unfortunately, Dr. Scutchfield passed away earlier this year, and you know our field lost a real leader. But I was happy to have had this opportunity to co-edit a book with him, and the book has 11 chapters in it, and 6 of those 11 chapters are either written or co-written by folks here at ETSU, and I think that's important because ETSU's had a long history of commitment to this region. And tonight you'll hear from Ron Roach, and I'll introduce him in a second. Kate Beatty and Melissa White wrote the chapter on social determinants, and Melissa will talk to us about that. Mike and his colleagues, former colleagues from Newark, wrote the chapter on diseases of despair, and Mike will be presenting for them, and then Angela and many of our folks here wrote the chapter on the opioid crisis. And Angela will present that. And then at the end, we'll have Q&A for any of the authors that happen to be here. So we'll start with Ron Roach. And let me just say something I've said about Ron many times. If you only read one chapter in the book, read the chapter that he wrote. It's one of the best descriptions of what Appalachia is, who we are, where the variables are, what it means to be Appalachian. And I can't think of anyone better than Ron, as he is, after all, the chair of the Department of Appalachian Studies in the College of Arts and Science. Never heard of that one, Joe. But anyway, please join me in welcoming Ron Roach.
Well, thank you, Randy. And I am happy to fly the flag for arts and sciences tonight. The College of Arts and Sciences. But I do want to thank Randy, Dr. Wyckoff, and the late Dr. Scutchfield Scutch for bringing me into this project. It has been a real pleasure. And I remember when Randy first asked me to do this, he said, I've got an easy assignment for you, Ron. It's an easy chapter. I want you just to cover the entire history of Appalachia and the current state of the region and do it in 15 pages or less. So I gave it a valiant effort. You're too kind in describing the chapter, but I really enjoyed the exercise, the challenge of it. It's been a delight to research and to write that chapter. But I think beyond that, the fact that you involved Appalachian studies makes an important point about what we all do here in the region. If we are going to successfully tackle the challenges in health and wellness and other areas in the region, then we have to have a holistic approach. And that's a strength of ours here at ETSU. We have to work together. And so we need public health, we need arts and sciences, we need Appalachian studies, we need Clemmer and Quillen and all the other colleges working together in a holistic way. And so I have just a few minutes tonight. I'll hit a few highlights from my chapter. And my chapter is introductory, it's background. And so for a lot of the people in this room, you've heard a lot of the things in the chapter, but maybe there are a few gems in there and it's organized in a slightly different way. But primarily the chapter is directed for those who are approaching this book and they don't know the history of the region or the current challenges of the region. And one of the most important points I think that I tried to make in the chapter and the book overall makes is that place matters. Place matters. Our environment, both the natural landscape as well as the cultural landscape, has a great deal to do with our quality of life, with our health, with our well-being, and every other aspect of us as humans. And in the chapter, I sort of start from the premise that for hundreds of years, people have tried to define Appalachia, and it's been elusive. Many have missed the mark and have defined the region in erroneous ways. There are many stereotypes and misconceptions about the region that we talk about in the chapter that you're well aware of. And in fact, it actually goes back to the very beginning, to the first time that they tried to define Appalachia on a map that we're aware of in 1562. This is a Spanish map, Diego Gutierrez. This is the first time that we have the appearance of the word Appalachian on a map. So if you zoom in, and if you really have good eyesight, or if you're on this side of the room, up in the upper left-hand corner below the coat of arms, can you see that word Appalachian? So that's the first variation of what became Appalachian applied to the mountains. But that from the beginning was a misnomer, because the early Spanish explorers encountered the Appalachian tribe on the Gulf Coast of Florida, down in Dr. McCorkle's neck of the woods. Still, we see that name there at Apalachicola and the Apalachicola River, but it was misapplied to the mountains and it's stuck ever since. And we still to this day have the debate, depending on where you're from in Appalachia, whether you pronounce it Appalachia or Appalachia. People print t-shirts about that, right? So down here it's Appalachia. And in addition to this, over the years, Appalachia, the region, has been a place that has sort of developed a mysterious reputation. And if you think about it, the landscape, I think, had a lot to do with that. So if you look at a topographical map of the region and sort of zoom out into space, the most dramatic, dominant geological feature in the entire eastern United States would be the Appalachian Mountains. And so there's no accident that these mountains had a profound effect on the early development of the United States. And so if you can imagine those early colonists settling that coastline, and even before them, back 15,000 years to the first inhabitants in this region, all aspects of life, foodways, economy, trade, transportation. There's a reason I-81 runs where it does, right? Because of the topography. And that's important to remember. Place matters. Now, it's also true that even trying to define Appalachia geologically is a challenge. You know, we've got a mountain range here that's more than 1,000 miles long in North America. It certainly goes well beyond the borders of the United States and into Newfoundland, but it then also continues under the ocean. You know, when we visit our friends in Ireland, they like to say when they're standing on the Sperrin Mountains, this is just another offshoot of the Appalachians. And if you go far enough back in history, they were connected to the mountains in the United Kingdom and to the Atlas Mountains in North Africa. So 500 million years old, one of the oldest mountain ranges in the world. Now, you can also try to define the region, of course, politically, and there have been many attempts to do that, the most significant being the Appalachian Regional Commission, founded in 1965, part of the War on Poverty, you know, a great partner to many of us here in the room. They currently, at least, define the region. And, you know, political definitions are always changing, so the number of counties is always changing. Just now, there are 428, last time I checked, in 13 states, more than 200,000 square miles, more than 25 million residents. If it were a state, it would be the third largest state in the Union. 42% live in rural or non-metro areas, which is significantly higher than the national average. But that's a little bit deceptive because the region also, of course, as we know, includes major urban areas. And a lot of the people who live in those rural areas are within a striking distance of a major metropolitan area. And that's something to remember. It belies the stereotypes surrounding the region. But it's certainly true that the higher regional population or rural population deserves a lot of attention in the region. When you talk about Appalachia, even though it's under the ARC definition, it includes more than 400 counties, most people, if you ask them to define the core of the region, they would look at this, what's called the consensus Appalachia, is defined by John Williams at Appalachian State, running from West Virginia down into the mountains of Alabama. And of course, this map graphically illustrates why ETSU is perfectly situated, perfectly located to be a hub for research and service in the region, because they're right there in the heart of that traditional core of the region. You know, another point I try to make in the chapter, belying the stereotypes, is Appalachia is a region of rich resources, both natural resources as well as cultural resources, historical resources. I took this photo up at Roan Mountain this summer. I think it was the most beautiful day I've ever seen on that mountain. And it reminds us of the incredible resources we have in the region. If you look at biodiversity hotspots, it's one of the most biodiverse places on the planet. More than 10,000 species of plants and animals, many of which you'll only find here in the Appalachian Mountains. And all of that runs counter to the negative stereotypes that have been pushed by the popular culture, popular media for so many years. And so we make that point in the chapter. It's something that we have to be aware of. It's also true, before I leave that discussion, in terms of culture, we try to make the point that culturally Appalachia is much more diverse than people think and people realize. When you think about the great music from the region, you know, what are the first things that come to mind if you think about the music of Appalachia? Bluegrass. That's great. Since that's in my department, I'm really glad somebody mentioned that first. Anything else? Ballads, maybe. The ballad tradition in Appalachia, old-time music. But how many people know that the father of blues music, W.C. Handy, was from Appalachia, from northern Alabama? How many people know that Bessie Smith, the empress of the blues, was from Chattanooga, or Nina Simone was from western North Carolina? So you've got this incredible diversity that people just aren't aware of. And we need to build on that. We also have to recognize, though, that it is a region that faces many challenges. We've made a lot of progress, but still we face many environmental challenges, mountaintop removal mining. More than 1,000 mountains have been leveled, an area the size of the state of Delaware. Just go to Google Maps and look at it. You can see it very clearly from the satellite view. And this has an impact through terms of pollution on the surrounding communities, and there are correlations to health and wellness with the environmental challenges. Economic challenges. We've made a lot of progress since the 1960s, but we still lag behind the nation on just about every major economic indicator. This shows each county's status as designated each year by the Appalachian Regional Commission. All those red counties are considered distressed counties. And there are only a handful of counties, the dark blue, that are equal or greater than what's happening in the rest of the country. Go down the list of economic indicators: poverty rate, unemployment, per capita income. You'll see us lag behind the nation on every one of those indicators. And then education, of course. And I think the book makes a good case, and Dr. Wyckoff, you address this often, that lack of education and the running behind in these health indicators, there's a correlation there. Poverty, education, and health, strong correlation, as is eloquently demonstrated in the rest of the book. So this is college completion rates, and only the brightest white counties, there's like a handful of them, are equal or greater to college completion rates in the United States as a whole. So yes, we have challenges in the region, but I conclude the chapter with these ideas. And I actually pulled this idea from the noted Appalachian writer Wilma Dykeman. She was from Buncombe County, North Carolina, and she wrote a fantastic book on the French Broad River Valley. And in that book, she made the comment that it was a place of paradox and promise. And I think the Appalachian region certainly still embodies that. It is a place of paradox. We have both incredible beauty here, but also devastation. We have a region that's been romanticized, but also vilified. We have a place of rich culture, but also extreme poverty. So you have these extremes, these paradoxes in the region. But beyond that, it's a place of great potential and great promise. There's so many good things happening in the region. The region has so much to offer the world. People are moving to this region because it has things to offer, and it represents a way of life and a quality of life that people want. But a big part of this, a big part of fulfilling that promise as a region is addressing exactly what these researchers are addressing in this book and in their daily work, and many of you in the room. How can we improve the health and the well-being of the people of this region? And so I hope you'll read the book. As Randy said, rush to get a copy before they sell out, and I'll turn it over to the next speaker.
Well, thank you very much, Ron. That actually is a wonderful introduction to the next chapter. The Social Determinants of Health, and it was co-written by Kate Beatty and Melissa White. Melissa is now a research associate with the Center for Applied Research and Evaluation in Women's Health. At one point, she was one of our students and has done reasonably well for herself. So please join me in welcoming Melissa White.
Can you hear me okay? Yes? Okay. Cool. I am Melissa White, White Archer, recently. And I'm really excited to be here today presenting to you all the book chapter entitled The Social Determinants of Health in Appalachia that I co-authored with Dr. Kate Beatty for the Appalachian Health book. So I wanted to start off with a little bit of background on the social determinants because I know not everyone has a public health background. So let's start with a brief definition from the CDC, which suggests that the social determinants of health are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And these determinants are defined by place or degree of social interaction with a certain place. So the Healthy People describes the social determinants or has defined 5 key social determinants that we in public health kind of talk about and investigate. So the 5 are economic stability, education, health and healthcare, neighborhood and the built environment, and then the social and community context. So all the terms that you see next to those bolded terms are ways that we can measure the determinants, and everything underlined, so poverty, high school graduation rate, or GED equivalent, access to health and healthcare, healthy eating, and social cohesion are all of the metrics that I'm going to talk about in relation to Appalachia today, and what we talk about in the book. So how did we assess the social determinants in Appalachia? As Ron mentioned, we use this map primarily in public health, which was developed by the Appalachian Regional Commission and highlights the 5 subregions of Appalachia, so southern, south central, central, north central, and northern Appalachia. So we used statistical tests to compare the average rate of the metrics that I mentioned in the last slide for the social determinants between Appalachian counties and non-Appalachian counties. And then we also looked at the difference between average rates within each subregion compared to non-Appalachian counties, because we wanted to see the variation within the region as well as the region as a whole. We used a variety of data sources to assess these determinants. Our 2 primary sources were the American Community Survey and county health rankings. So now I'm going to move into our actual assessment of the social determinants in Appalachia, but I want to draw your attention to the significance legend. So the more asterisks that a graph has, the lower the significance level. And then if you see a little Y symbol, that indicates that a metric is better than the non-Appalachian US, or a T metric is more representative of like a worse trend than the non-Appalachian US. So I'm going to go in the order that I originally discussed the determinants in that background slides. I'm going to start with economic stability. So we measured economic stability using poverty and median household income as a measure of poverty. So economic stability is important because income and life expectancy are positively associated, but that strength of association can depend and vary depending on geographic region. So what I want to highlight in this graph in particular is that Appalachia had a significantly lower median household income overall, and then you can see that same trend in Central Appalachia, North Central Appalachia, South Central Appalachia, and Southern Appalachia in this graph. So moving on to education. We measured education or assessed education using the high school graduation or GED rate. And education is important in this context because it has been defined as the principal pathway to financial security, stable employment, and social success. However, the possibility and quality of education can vary by social factors, environment, geographic region. So again, in this graph, you can see that Appalachia has statistically lower high school graduation or equivalent rates compared to non-Appalachia, which are the two top bars. And then you can see that Central Appalachia, South Central Appalachia, and Southern Appalachia follow that trend, but Northern Appalachia actually has a significantly higher high school graduation rate compared to the non-Appalachian US. Okay, so the third social determinant that we talk about in the book chapter is health and healthcare, and we assess that using a metric that assesses access to primary care and mental health providers. So something important to consider before I go into what's in the graph for this particular slide is the fact that we're looking at population to provider ratio. So the smaller the better. So if you think about like classroom size, you want a smaller number of students to a single lecturer. It's the same thing here, you want a smaller population to provider ratio. So you can see here that Appalachia as a whole was not statistically significantly different from non-Appalachia when it comes to population to primary care physician ratio. And you can see in the bottom half of that graph on the left that Northern Appalachia actually has a significantly smaller population to primary care physician ratio, which is great, but that Central Appalachia and Southern Appalachia have a significantly higher population to primary care provider ratio. So access is more limited in those regions. And then the graph on the right is mental health provider, population to mental health provider ratio. So in this case, Appalachia has a significantly higher population to mental health provider rate overall compared to the non-Appalachian US. And then below that, you can see that the southern subregion follows that trend as well. Okay, so on to the fourth social determinant, neighborhood and built environment. So the neighborhood and built environment is important because it can impact access to healthy foods and physical activity levels, because it's like the physical structures that people are exposed to. So like location of your house, the existence of sidewalks, the existence of like good, actually accessible sidewalks, and like proximity to grocery stores. So we measured this one by looking at access to foods that support healthy eating, and we did that through the Food Environment Index, which is a metric that is in the county health rankings. So it takes into account individuals or county level proximity to healthy food, as well as county level income rates. So you get kind of both sides of that access to healthy eating. And then the Food Environment Index is a score from 0 to 10, 0 being the worst, 10 being the best. So what you see here is that Appalachia actually has a significantly higher Food Environment Index compared to the non-Appalachian US. But if you look below in the bottom half of the graph, Northern Appalachia actually is kind of like carrying that trend because it has it's the only one that is significantly different than the non-Appalachian US, and it's significantly higher. And then the final social determinant that I'll talk about is the social and community context. So this one is a little bit more nebulous, but essentially we measured social and community context through something called social cohesion, which can relate to social capital, which is like networking and access to relationships and things like that. And we measured social capital using a county health ranking measure called social associations, which is access to like memberships to things like country clubs, professional organizations, fund or like extracurricular organizations, things like that. So when looking at social association comparison between Appalachia and non-Appalachia, Appalachia had significantly less social association opportunities compared to the non-Appalachian US. And you see that trend in central as well as southern Appalachia, but again, northern Appalachia is trending towards having more than the non-Appalachian US. So I know those were a lot of numbers and a lot of words thrown at you, so I did put together a summary slide to kind of talk about what all this kind of means. So essentially what we did is compared all these groups, and what we found is that compared to the rest of the US, Appalachia had a lower median household income, a lower percentage of the population with a high school diploma or equivalent, a higher population to mental health and primary care physician ratio, a higher food environment index, and a lower number of membership associations. And then looking within the region, Central Appalachia consistently had metrics that were more in the direction of like worse compared to the rest of the US. So why is all of this important? I think the ultimate goal of this chapter was to highlight the fact that health behaviors and outcomes don't occur in isolation, and that Appalachia has a disproportionately high rate of adverse health outcomes and adverse health behaviors. But understanding these social determinants provide context to why maybe some of those health outcomes and behaviors are occurring, and understanding that can help us identify or develop interventions to help improve and reduce these disparities. And that's all I have today.
All right, thank you, Melissa. That was great. Now up is Mike Mead, who's the co-director of the Center for Rural Health Research. And I think Mike is one of the national experts on diseases and deaths of despair. And I think you were actually working on this chapter before you came here. It took him a long time. So please join me in welcoming Mike Mead.
I'm going to put this here. So my wife asked me whether this was going to be uplifting. So I'm going to talk about deaths of despair, otherwise known as diseases of despair. So I can promise you right now, this is not going to be uplifting. So this is work that we did here jointly between ETSU and NORC, and it was done for the Appalachian Regional Commission. I'm going to talk a little bit about what diseases or deaths of despair are, but this is coming to kind of common terminology. It was a term that really came about from some economists at Princeton, and they looked at what was driving declining or increasing death rates, what was declining life expectancy. And what they noted were there were three primary causes of death that were really affecting that: overdose, suicide, and alcoholic-related liver disease. And kind of put together, they thought about, well, what's behind these? And they thought about this as despair. So if there's joblessness in a community, if there's hopelessness in a community, these things naturally occur following that. And then we kind of took that to the Appalachian Regional Commission and said, well, this may be a way to frame some of the things that are happening in Appalachia. They like that. And so they funded us first in 2017 to do this study looking at 2015 data. So we're using CDC data, and CDC data lag by 2 years. So you'll always see this 2-year lag. We updated it in 2020 using 2018 data. At the point that we wrote the chapter, those were the 2 data points. I'm going to share mostly that. But the good news is we're currently working on the update now, 2022, using 2020 data. And in doing so, I'm going to share with you some of the preliminary data that has not been seen by anyone before. The other thing I do want to let you know is I am going to try to end on a somewhat positive note. We have a new tool that we are releasing tomorrow, and I want to give you a preview of that as well, and I do think that's a very positive thing. So here are the findings, and I'll try to walk you through what you're looking at because I know it's kind of small on the screen. But this is including, so this is data across time, and it includes the most recent data from 2020. And what you see on the left is all-cause mortality, and you'll see this disparity. The yellow line is the US as a whole, blue line is Appalachia, and you see this ongoing disparity between our region and the rest of the nation. What I want you to see is now that we bring in the 2020 data, this is COVID-19, of course, we see this huge spike in mortality, all-cause mortality. What's interesting about that is that when we break this down and look at these 3 causes of death, suicide, overdose, and alcoholic-related liver disease, that's what you see on the right. So it's those 3 causes of death aggregated. So that's not COVID-19 directly, but those are the effects of COVID-19 still. So even in 2020, and again, that's the first year of the pandemic. We don't have 2021 data yet. First year of the pandemic, we saw these huge spikes. What's particularly depressing for a lot of us who do this work is if you follow that blue line, 2018, we had the first decline in overdose mortality, and that drew down deaths of despair, first decline in decades. And we were all ready to spike the football, high-five each other. Unfortunately, 2019, it remained relatively stable, but once COVID-19 came into the picture, the rates just spiked. And then this just looks at that same data. This is specifically overdose mortality, which drives most of this data. You see that exact trend. So these are overdose deaths. You see this very significant growing disparity. We had this exciting moment where the rates went down, they remained stable, and then they've gone up dramatically during COVID-19. And that's what we're really seeing now. If you look at this, so when we were looking at this initially, 2015, the rates were around 34 per 100,000. Now they're almost double that, 58 per 100,000. So huge, huge spike in a very short amount of time. So I want to walk you through a few of the key findings here. So this goes back to the book chapter. This is the 2018 data. This is a slide where we're able to show kind of all the high-level data across these deaths of despair together. So across these deaths of despair, blue is Appalachia, yellow is the rest of the United States. You see this disparity across all of them. So overall, there's a 36% greater likelihood of dying as a result of deaths of despair in Appalachia, 48% higher in terms of overdose, 30% higher in terms of suicide, 13% higher in terms, 30% higher in terms of suicide, that's right, and 13% higher in terms of alcoholic-related liver disease. All told, that's about 12,500 deaths. About half of those are overdose deaths. This, to me, may be the most important slide when I talk about this issue. So this is essentially the same data, but this is broken out, first of all, by males and females, males on the left, females on the right, and by age. So you can't really see it here, but I want you to focus on 2 things on this slide. So this 25 to 44-year age group, that's these two here for women, that's where the highest rate is. So about a 50% greater likelihood of dying from deaths of despair in that age range for males, about a 70% higher likelihood for females. The other thing I want to point out here, and this is a trend we see throughout our region, is that rates are higher for men, disparities are greater for women. But the reason I point out this age group is that the rates are highest among that 25 to 44, and what's important about that age group? That's people who are raising children, so we need to think about those adverse childhood experiences. That's our workforce. So this is an economic development challenge for our region. That 25 to 44 age group, that's where so much of this happens, and that's a big challenge for our region. This is really just looking at this by state. So you have West Virginia, Maryland, Ohio, Kentucky on down. what you see when you look at these issues by state is Central Appalachia has the greatest burden from deaths of despair. Southern Appalachia, this is at the bottom, Mississippi, Georgia, Alabama, Virginia, relatively lower rates. It's interesting, there's an interesting discussion to be had there, but relatively lower rates in terms of deaths of despair overall. And then when we, again, look at this only by overdose, you see the same trends that I talked about. 25 to 44-year age group is the highest risk. The rates for men are 50 to 60% higher. The rates for women, 90% higher to 100% higher. So just you put it into words. If you are a woman in the Appalachian region, age 15 to 64, you are twice as likely to die from overdose as women in the rest of the United States. Huge, huge disparity for women, and for both men and women, but particularly for women. And then same thing you see, and again, this is just overdose, but you see Central Appalachia is where we have the highest overdose rates. Rates are relatively low, lower actually than the rest of the United States when you get down to Southern Appalachia. And when we break it down by the cause of overdose, about 70% of the overdose in the region are attributable to opioids. So this is what's interesting to me now that we have this 2020 data, is looking at this over time. So this is a comparison. This is in the middle, the chart that I showed you before. This is the 2015 data, this is the new data. They look kind of smooth because we did these separately for the book and the report for ARC. But if you look at the rates, so this is the overdose category. So the rates in Appalachia were 35.4 in 2015, 41.6 in 2018, and 58.5 in 2020. So again, these rates have spiked. What's interesting though is the disparity between Appalachia and the rest of the country has gone down. So the rates in Appalachia were 65% higher in 2015. Now they're about 50% higher, and this is one of those public health things you always need to point out to you, is it's great to close health disparities and health disparity gaps, but you don't want to do it by the people who are doing better than you suddenly getting worse. So our rates have continued to go up. Everyone else is catching up to us at a very rapid rate, and that's not a good thing. Overall, the rates are relatively the same across all three causes of death, around 35, 36% higher. Other thing I want to point out to you here, between 2015 and 2018, when we looked at suicide, the rate went from 20% higher in our region to 30% higher in our region, so a 50% increase relative to the rest of the US. And then when we look at alcoholic-related liver disease, it went from 8% higher to currently 16% higher in 2020. So that disparity doubled in our region. So again, we talk about overdose a lot, but it's not the only challenge we face. And then this just looks at it by sub-region. So when we go back to 2015, it's really the central part of Appalachia that has the greatest burden. North Central spiked in 2018, and now it's really central again. And again, if you look at the numbers here, it's a little hard to see, but in 2015, the central region was 94.4 per 100,000. It's now 137 per 100,000. That's a huge increase over a 5-year period. And what's interesting about that is even as that happened in Central, North Central went down from 109 per 100,000 to 95.5 per 100,000. So this didn't work out evenly even during the pandemic. So these are just the key findings. So the declines in the deaths of despair and drug overdose mortality rates occurred between 2017 and 2018, but we've seen this dramatic increase in 2020. The shifts have really been notable in the subregions, what I just shared with you. Notable increase in North Central Appalachia in 2018, and now in Central Appalachia in 2020. Between 2015 and 2018, we saw that dramatic increase in terms of suicide. Between 2015 and 2020, we saw that similar dramatic increase for liver disease. And then as I keep mentioning, because it's such an important finding to me, the burden is higher for men, but the disparity is greater for women. And that's all I'm going to share with you on deaths of despair. But before I leave, I do want to share with you some good news. So we have been working over the last year on a tool, the flip side of this. We've been trying to think about how do we help people achieve recovery and sustain recovery. So this is positive. So what you see here is just a graphic model of what we refer to now as a recovery ecosystem. The idea behind a recovery ecosystem is providing support for people so that they can sustain their active recovery, things like transportation and housing and access to treatment and all of these things that are really important for people who are in recovery to stay in recovery. Jobs, probably number one on the list. So we came up with this tool, and these are you can't read it, you're not intended to read it, but we came up with an index comprised of 14 measures, a lot of substance use disorder, access to treatment measures, social measures, environmental measures, 14 measures that we thought were important indicators of the strength of that recovery ecosystem, the availability of those supports for people in rural communities all over the country. And using that, we developed this tool, which is live now. It went live today, rei.norc.org. I'm waiting for the trademark infringement from REI, but it hasn't happened yet. We'll cross that bridge when we get there. This is the national tool. So this is a mapping tool where you can click on any map in the country and it will pull up data for your county. So you can see how your county scores in terms of the recovery ecosystem index, but also in terms of drug overdose mortality rate. And you can access all of that data, every one of those 14 measures for your county, see the areas where there are deficits in your county. And the idea here is to look at those counties that have high overdose mortality, but low recovery ecosystem scores, and target resources and technical assistance to those counties so that we can help them strengthen. And press release goes out at 9 a.m. tomorrow. Tool is live now. We're really excited, and we developed this. Actually, I should give credit where it's due. It's funded by HRSA, the Health Resources and Services Administration, funded through the Fletcher Group, which is a national nonprofit technical assistance center, and then ETSU and NORC developed this together.
All right, thank you very much, Mike. And finally, we have a chapter that, and you will now understand why this chapter is so important based on what Mike was just talking about, the opioid crisis in Central Appalachia. Angela Hagman is going to be presenting on behalf of the team, and Angela is the operations director of the Addiction Science Center, and again, this is the third of our research centers to be highlighted in the book, which I think also reflects the commitment that this university has to this region. So, Angela.
Thank you very much. Thanks.
The advantage has been used so much, the euro is on.
Hey, everybody. You hanging in there with all this depressing data? There's some good stuff happening, too. I'm glad to be here, and I will acknowledge each of my co-authors, Dr. Bill Brooks, Rob Pack, Stephanie Mathis, and Kelly Moore. I think 50% of you are here today. So I'm going to share some more data about Appalachia and some good work that's being done in our region. I did bring notes so that I quote my statistics accurately. So I want to say that a lot of you might learn about the opioid crisis from your local news channels, from Netflix documentaries, Hulu documentaries. Some of this information is really helpful and valid, and some of it might be misleading. So again, we're going to challenge some of the stereotypes that you might have heard about. So I like to start by sort of sharing these two slides. We look at 2003, which is the map on the left, and 2016. And in 2003, there were very few counties in our nation that were experiencing overdose death rates at 30 per 100,000 or more. There's only one place in the country that had contiguous or counties that were touching each other that had these higher rates, and that was in Appalachia. So we knew then that we were having a problem. And many in our community were sounding the alarm bells. We see in 2016 that there were many more areas of our country experiencing those higher rates of overdose deaths, and we've heard of rates much higher than that from Mike and others' data today. So as of 2017, 1.7 million people in the US were suffering from a substance use disorder related to prescription opioid pain relievers, with another 652,000 suffering from a heroin use disorder. Presently, more than 130 people die each day from an opioid-related overdose. And I will say, every number that I'm sharing, every statistic is a human being, a mother, a father, a sister, a friend, and many of you have experienced loss, I'm sure, from this crisis. So since the 1990s, there have been 3 overlapping waves of opioid-related overdose deaths. So the second wave, I'm moving through my notes way too fast here. And so the trend started in the late 1990s, where we saw a rise in opioid overdose deaths related to prescription painkillers. We know that there were many drivers that were associated with this rise in overdose deaths, but particularly we know a lot more about the pharmaceutical industry's role that they played in this rise in opioid overdose related deaths. So we see here that from 2006 to 2012, again, we have 2 maps. The map on the left, I know it's hard to read, but from the DEA, we see the number of pills dispensed to certain areas of our country. So the areas that are darkest red are areas where the largest number of pills were disseminated or distributed in our country. So what we know here is that the top 4 states with the most opioid prescriptions per person during those 6 years were West Virginia, Kentucky, South Carolina, and Tennessee. And we know that in Appalachia, so the map on the right are overdose-related deaths, and you can see that you could almost put those maps on top of each other. So we know that the higher rates of overdose-related deaths were in areas where most of these pills were disseminated. One case example is during the 6 years that those maps are representing, pharmaceutical companies shipped 306 opioid pain reliever prescription per person to every man, woman, and child in Norton, Virginia, a municipality with only 4,000 residents. So during this time, during this wave, we know that we enacted a lot of legislation to try to control the supply of these opioid pain relievers. One thing was the prescription drug monitoring programs that most states adopted that required prescribers and dispensers to log in their opioid prescriptions. But during that same time, when we began to see that attempt to control the supply, at about that same time, we also saw the beginning of the second wave of the opioid epidemic with heroin coming in to backfill that demand. So this second wave happened during multiple efforts to constrain the supply. So in 2007, the number of overdose deaths attributable to opioid pain relievers was greater than those associated with heroin and cocaine combined. However, in 2010, you can see the uptick there. Deaths associated with opioid pain relievers dropped, and heroin and overdose deaths tripled. So given the persistent variability in potency and the quality of illicit drugs and the ever-rising tolerance among people with opioid use disorder and people who use heroin, the third wave of overdose deaths commenced as dealers began to adulterate the heroin supply with fentanyl, and many of us now have heard about that. And we know that fentanyl is a synthetic opioid that's 50 times stronger or more potent than heroin, and is used by dealers at all levels as an adulterant to maintain and increase the potency of their merchandise. We're seeing this in methamphetamine, we're seeing this in cocaine, so it's showing up in all different drug types. So from 2013 to 2017, Appalachian communities experienced an 817% rise in fentanyl-related mortality, a rate that was 72% higher than the rest of the country. And in 2020, fentanyl caused more deaths than either heroin or prescription opioids. So this is a complicated problem. No longer is it a prescription pain reliever problem or a heroin problem or a fentanyl problem. It is a complex, interwoven problem or a syndemic in which there's no single opioid overdose epidemic, but multiple opioid mixtures. And this, I think this is 2018, 2019, this begins to show sort of the complexity. So we know that 25% of counties in our country are severely impacted by overdose death, opioid overdose, but not in the same way. There are distinct and unique epidemics in multiple subregions that you can see here are represented. They look differently, and so it's more complicated to address this. And we know that a small share of counties, about 4.2%, are experiencing 3 coinciding epidemics of prescription, heroin, and synthetics like fentanyl. and this is what we term an opioid overdose syndemic. So many central Appalachian counties are suffering from those three, that syndemic. So this is a slide that we've been showing for many years. A group from our Addiction Science Center put together this compendium in 2018. It's a series of interventions that can be deployed across the continuum of disease. So we know that the opioid crisis cannot be solved rapidly or by a single strategy or sector. There's no silver bullet, unfortunately, but persistent and coordinated implementation of proven strategies with consideration of intended and unintended consequences will help advance public health. We know that in prevention, proven interventions for young people remain underused in the context of this epidemic, and addressing modifiable risk and protective factors can make a substantial difference. Many of you are working on adverse child experiences, trauma-informed care. We also know that because people with opioid use disorder have high relapse rates, it's very important that we know about the most effective treatments, which are medications. That's buprenorphine, methadone, and naltrexone. We also know that despite considerable emphasis on the accessibility of these medications, many sectors still do not allow the use of these medications. Particularly one setting in dire need of OUD treatment is the criminal justice system, due to high rates of fatal overdose for persons transitioning from corrections facilities back into the community. However, very few U.S. jails and prisons offer this type of treatment. We also know that harm reduction is important. Not everyone is ready for treatment or recovery, and so we know that access to Narcan, the opioid overdose antidote, and also syringe service programs can save lives and keep people alive until they are ready for treatment. And so this is an article that shows the different levels of promising practices and interventions across the continuum. And there is a brief from the Appalachian Regional Commission. Many folks in this room actually co-authored this piece that support these interventions and made them specific to community-based interventions in Appalachia. So that's an important resource if you want to sort of do this work. We also need to pay attention to the fourth wave. Unfortunately, we're seeing a fourth wave now, and that we know that the epidemic is evolving sort of as we speak, as we meet today, and methamphetamine use alone and in combination with opioids is surging in Appalachia and nationwide. A recent report demonstrates an 82% increase in past month methamphetamine use among those patients in outpatient methadone treatment programs. And so we have to be innovative and partner together. We know that while we now have attention to this, and there's a great deal of funding coming down from opioid litigation, NIH, and many other funders, it's taken decades to get this level of attention. So we'll need to be vigilant and innovative through our partnerships so that we can begin to see decreases in overdose mortality. And I am encouraged by the work that I'm seeing in our community coalitions, our peer recovery support specialists, many people in this room who are coming together and partnering with universities and health systems to mitigate risk and improve health in our region. So that's it for me.
All right, so now, thank you, Angela. That was great. We're going to do the question and answer portion, which will not only include the folks that spoke, but also there's several other chapter authors here. If the questions are too difficult, we'll refer them to them. But I do want to say one thing. I think you can appreciate how easy it was to edit the book when you have authors like the ones that we heard today. But I also hope that you all appreciate what a pleasure it is to be at an institution like ETSU that really cares about the region. What you've heard is folks that are really expert, involved, and caring for the region. So at that point, let's, if you will signify by raising your hand, I'll bring the microphone to you and you can direct your question to anyone except me. Joe?
This is directed to any of the authors that want to answer it, but the thing that really impressed me in hearing all of these presentations is the differences in the sub-regions in Appalachia. And it's to the point where when folks talked about Appalachia, I thought, well, which subregion? Is there sufficient focus in the health space on those particular subregions? I mean, it seems like Central Appalachia is really one that's struggling. And are the resources being distributed according to those subregions, or is it more, looking at it across the board as Appalachia as a whole?
I'll take a quick answer at that. I think there are the major funders in the region, I think, are looking primarily at economic problems and trying to recover, especially in the post-coal era. And so I would say there's not a really sharp focus on the health needs of the people of Central Appalachia, at least from the funders' side. But let me, Mike, Ron, anybody? Yeah.
So I think that's true. To the extent that the economic challenge in the region coincides with the health challenge in the region, I do think there's a lot of focus on Central Appalachia, and I think a lot of the opioid focus has been on Central Appalachia. So it's kind of hard to separate out the economic distress from the health challenges that follow. So I do think particularly Appalachian Regional Commission, which at its core is an economic development agency. They are investing in that region, that sub-region, thinking about how do we improve health and well-being so that we can improve the economy. That's where the focus is needed. Beyond that, I think most of the federal funders, and that's mostly who I'm engaged with, when you're writing those proposals, you have to demonstrate need. And I think to the extent that you do a good job of that, you can bring resources into those regions. I did a study, just as an example, looking at declining overdose mortality rates in eastern Kentucky, which is, from Ron's, he showed the slide with economic distress. That is the most distressed region of all of Appalachia. That's where we have the most distressed counties in the entire region. A lot of community effort and funding from the state and the feds, and they were actually able to turn the corner. Now, they've lost progress during COVID, but they did something very unique in that region, and I think it was a demonstration of the investments that happened.
Angela?
I think the only thing that I would add is that NIDA funded our team to do, I think it's a little unusual to do studies to advance recovery support. So we have a NIDA funded grant to study opioid overdose and peer recovery supports and medication clinics that provide medications for opioid use disorder just in Central Appalachia. So I don't hear about that a lot. It's generally broader, but we do have a 5-year study focused just on Central Appalachia.
Yeah. Right.
As we're seeing people move into the region from urban areas, is there an opportunity to capitalize on that, maybe from a higher socioeconomic status, education status?
I'll take a shot at that. I sometimes ask people, why is Washington County healthier than Unicoin County? It's because most of us moved here and live here. So one thing we have to be careful of is when people move in, the statistics can get better, but the underlying problems are still there. So we still have hidden poverty. Now, what you hope is that as people move in, they invest more in the community, and that creates more jobs. Jobs create opportunities, and so on. So we have to be a little bit careful, but I think the answer is yes, it can help. Nobody disagrees with me enough to talk, okay? Yeah, Ranjan. And I don't know everybody in the room, just the people that raise their hands.
So I also wonder that all these determinants that we saw the data, has anybody studied with how this is related to the family structure? Because it's very deep, it's very difficult to address any of this right from the top, because you've got to find out the root cause of poverty, root cause of lack of education, root cause of why doctors don't want to move to rural area because they also want to raise their own family. So there are many causes combined that you see the results. So are there any studies that relates to family structures and things like that, like totally social factors?
You get volunteers or calling someone?
I'll speak a little bit about some of the work we're looking at around grandparents as caregivers. And so we have been looking at the overlay of the opioid epidemic and overdose mortality with the increase in grandparents as caregivers. And so when we look at that, the region has a higher rate of grandparents as caregivers to other regions. And you can look at that a couple different ways. But part of that is a deep connection to family. And so when things happen in families, people either can, being grandparents or other family members, step in the region at higher rates than other places. So we do have this cultural tradition of family in the region that doesn't get at what I think you're asking about, bringing people into the region, and challenges with getting kind of the populations that Randy was mentioning, the higher economic communities to come in. I think that's a different issue. We have great resources that we only have here. I don't know, when you drive into campus, I look around and I'm like, I get to live here. I get to drive through these mountains. So I think more people are knowing and learning about where we are. Our university is getting more recognition, and so that helps. But we also have to create opportunities community-wide, collectively. It can't just be those with the haves having more. So.
Yeah, so one of the measures I like to look at a lot, and it refers to that whole distressed region in Eastern Kentucky, but it's the measure called persistent poverty. And this is a USDA definition, and to be defined as a county as a persistent poverty county, more than 20% of your population needs to live below the federal poverty line since the 1980 census. So 1980, more than 20%, 1990, more than 20%, 2000, more than, on and on. So these are counties that have 40 to 50 years of intergenerational poverty. The reason I mention that is that it's intergenerational. And I think part of what you're alluding to is how do we break these cycles? And I think education, we're a big part of that here. I think education is key to breaking those cycles, but also creating opportunities in these communities and providing just people with a different path. So I keep alluding to this work in Eastern Kentucky. I'll just tell you a tiny bit about it because it's probably some of my favorite work because I get to highlight good things happening in Appalachia, which is what we like to do. But when we looked at every county in the United States, almost 3,200 counties, and rank ordered every single one for who has the steepest declines in overdose mortality, of the 10 counties in the entire country with the steepest decline, 8 of those 10 were in Eastern Kentucky, and they were all persistent poverty counties. So, when we think about things like the social determinants of health, I don't like calling them determinants because, boy, if it were predetermined, these counties couldn't do that, right? So to me, it's an inspirational story of what you can do at the community level if people come together to break these cycles. And I think it's a demonstration that these things aren't predetermined, that it can actually happen.
I don't know. Yeah, I don't know your name, brother. Move along. Rob, there you go.
Hey, Rob Pack. If I could just add that a lot of that was built on the recovery ecosystem development that was really focused on in Kentucky and facilitated by expansion of Medicaid.
David?
Thanks, Randy. So just going back to your comments at the beginning in terms of looking inside was your frame for tonight in terms of what the purpose of the series does. But what I saw tonight was a lot of what Dr. Roach explained and the paradox of promise and things that we're doing. And I wondered if someone could comment on what people are looking to us to do outside of the Appalachian region and how they're using some of these wonderful things we've heard tonight in terms of progress across the country and other areas.
I think both Ron and Mike are sort of at the cutting edge of, Ron does a lot of work with other parts of the world, and maybe I can let you speak to that.
Right, and I think Mike can speak more directly to how the research and the cutting edge, I'm very excited about this new approach you're developing, how that's being used by other parts of the country and other parts of the world. We have been doing a lot more work in sort of international mountain studies, comparative mountain studies. You know, I started off by saying place matters. And mountain landscapes, dramatic landscapes, they tend to, the people who live there tend to face similar challenges around the world, understandably. So I think that the Appalachian region and the work that's developed here certainly is having an effect outside. We've had some interesting conversations lately with the Delta Center over in Mississippi. They're very interested. They found us by accident online. They said, you're doing at ETSU exactly what we want to do here. We want a partnership. And so Mike and Randy and I have been having discussions about that. And in other parts of the world, for example, in the Carpathian Mountains, where I've done a lot of work, the whole concept of regional studies and regional cooperation and nonprofits working with governmental entities is just a new concept. It's a foreign concept. And so the more we can sort of export this cooperation, this interdisciplinary work that we're doing, I think it can have a tremendous benefit in other places around the world that are facing some of the same challenges. And they're certainly not all mountain regions. We saw that on your map. Rural places, though, experiencing the same challenges. Mike?
Yeah, and so this is where I start to go on a guilt trip, because I feel like as researchers, we often become part of the problem. I think it's something we need to be very cognizant of. So, you know, whenever we do a Diseases of Despair report, we get great media attention. It's not positive messaging around our region. So I do not do an interview with a reporter anymore unless I finish that interview and talk to them about the good aspects about our region, about our communities. 9 times out of 10, that doesn't show up in the articles. So here's kind of what, and I gave a presentation a couple months ago to a group of rural journalists, and kind of the way I describe this to them is that we will do a study where we say 10% of the people in our region face whatever issue. 5% of the people around the rest of the nation face this issue. It's twice as bad in our region. And we will get these big stories, you know, twice as bad, you know, oh, Appalachia has this problem, this problem. And what we never ever do is talk about the 90% of the people in our communities who are healthy, hardworking, looking for opportunity, wanting a better future for their children. We need to make sure we lift up that part of the narrative, because I truly believe this. I think that if we can keep these investors, who are usually in urban areas reading these stories in their media, if we can keep them from having this negative image of our region and get them to invest in our region, they're going to find a bunch of people who are hungry for opportunity. I think it's the best investment they can make. We need to be able to tell that story so that we can lift up our people, because when it comes down to social determinants, if we lift people up economically, the health aspects will follow.
Thank you, Mike. And Ron, I've got a question over here, and then I'll come right back to David.
Thank you. Hi. We're just community members. We're not associated with ATSU, but of course we're very interested in this situation. We're fairly new in the region. Been here about 6 years. We recently saw the movie Dope Sick. I'm sure most of you all in this room have seen that. The observation, I really just have an observation, is the movie, if you haven't seen it, I recommend it. And they call it more or less a docudrama. And it's mostly about the Purdue Pharma and the Sackler family's role in this whole disaster. But I've often wondered, where do people come from that they actually, do they just wake up one morning and say, I'm gonna go wreck my life with an opioid? Or more importantly, the movie, that what I took away from it was part of the reason that people go to their doctor in the first place is because they have suffered employment-related injury related to coal mining and other industries that are unique, more or less unique to this region. So I wonder if any of the researchers have a comment about that. Is that really something that, because I just don't get where it all starts, and the movie suggests it. I'm just not saying that that's the case now, because coal mining is not what it used to be. And there are other reasons, but that was of curiosity to me. Thank you so much.
It's a great observation. Rob, you want to address it?
Yeah, I think you're absolutely right. The coal mining, extractive industries, timbering, things that are high injury focused, or high injury resulting occupations, and then unemployment, and then feelings of despair, right? And then seeking some sort of way of dealing with those feelings and that situation, and becomes a sort of a cyclical problem, a self-reinforcing problem in a negative direction. So I think that that's part of it. I do think that Beth Macy, who wrote that book, Dope Sick, and who interviewed many of us in the room for that book and her next book, Raising Lazarus, which I recommend everybody read, by the way. It's a great book about how to get your hands dirty and beginning to tackle this problem. And it's out now. It came out a couple of weeks ago. Anyway, I think that she does a really good job of describing sort of that natural history. And you know, I think your point is right on.
Thank you.
Thanks, Rob. David?
I'm just wondering, I know we have the Appalachian Regional Commission as a force that's trying to raise up economic development and cooperation. Are there other efforts? You know, I almost feel like Appalachia, I'm not a native to this part of Appalachia, I'm from the northern part in western Connecticut, where we call it Appalachia, not Appalachia. But, you know, it's like West Virginia was the one state to have the courage to kind of break away and say, we're our own thing. I'm wondering about, like, you know, how much teeth the Appalachian Regional Commission has, if there are other efforts for interstate cooperation for the region, because, you know, we're very different from Memphis and like that part of the state. We're very different from Birmingham and Atlanta, which are adjacent to Appalachia, or, you know, maybe not Birmingham so much, but Atlanta's certainly an economic powerhouse. Pittsburgh in the northern part, another, you know, it's declined, but it's coming back up. Where are the efforts at cooperation in terms of training, jobs, policies, et cetera, that link the region together? Because it really, you know, I think our region has more in common with West Virginia than it does with Nashville.
No, that's true, and as many of you know, we are physically closer to Canada today than we are to Memphis. True story.
So, you know, I think, the Appalachian Regional Commission is truly a model. Delta region has tried to create their own Delta Regional Authority, their U.S.-Mexico border region. There are other regions around the country that have tried to model themselves with less success because ARC was established with money and as part of the war on poverty. And the other entities just never got the same footing. ARC is a force for good in the region. They do phenomenal work. They do connect people. They have a phenomenal annual meeting. They bring together all of the 13 governors from the regions, from across the region. They do great work. The thing with ARC, though, that you always have to keep in mind is that at its core, I mentioned this earlier, at its core, it's an economic development agency. So they have a health focus. But the health focus is how do we make people healthy so that we can improve the economy. They have an education focus, but the education focus is how do we improve educational attainment so we can help the economy. So at the end of the day, thinking about how do you tie whatever you're doing back to that economic development. That's what ARC is looking for. But yeah, I think they do a great job across the region, and I don't know that there's anything else quite like it around the country, although there are a lot of other entities that aspire to it.
There's a few efforts like Appalachian Funders Network and a few others like that, but by and large, most of the philanthropic efforts in Appalachia are more regional, like Western North Carolina and so on.
So the Appalachian Funders Network, and Kate and I had done some work for them. They're a really interesting one though, because it's mostly small philanthropies throughout Central Appalachia that realized that individually they didn't have enough resource to make a big impact, but collectively, if they pooled their resource, they could make a much bigger impact than any of them could individually. So I think there's a model there, and there are other philanthropy groups like that that have come together around the country. But AFN, they were really great to work with, and I think they're a good model here in Appalachia that others could model from as well.
Well, we're out of time. A couple of quick announcements, and then we'll do another round of applause. The next Leading Voices will be on October 13th. It will be the second Health, Equity, and Inclusion lecture, which is co-sponsored by a number of folks across campus. Dr. Hildreth, who's the president of Meharry, will be our speaker. We'll get an announcement out, but go ahead and mark your calendars. The second announcement is that there are still books for sale. And yes, it is true that I get a small royalty. And in order to make that fair, I have made a commitment to give all them to the shared library. So let's give our speakers one more round of applause.